So the ARIEL3 trial was done in a population that was similar to NOVA. They had patients that were platinum-sensitive responders, and they were then randomized to Rucaparib, 2-to-1 randomization, as the others were, versus placebo. This trial was ultimately presented in September of 2017 at the European Society of Medical Oncology, and it also showed a very strong effect on the delay of progression, just like the other two trials had done. As aligned with SOLO2, this was an investigator-assessed progression-free survival endpoint, so they shared that similarity, but it was in a much broader population. And slightly different than the way NOVA allocated their patients. In other words, in NOVA, I mentioned there was a germline patient population, and then there was everybody else. In ARIEL3, it was just everybody else. But what they did was what was called a step-down procedure from a statistical standpoint. So they looked at the patients who were germline or somatic, so BRCA mutation carriers or BRCA mutation in the tumor. That was one cohort. If that was a positive result, then they expanded it to the HRD population. So that included the germline and somatic patients, but also now the HRD patients. And in this particular trial, the HRD assay was assessed by a different methodology. Again, it was using loss of heterozygosity as the global kind of review of how damaged the DNA repair mechanism was, but it was done by the Foundation Medicine test as opposed to the Myriad test, which was done in NOVA. And if the second population, the step down into the larger patient population, was positive, then it extended the analysis to all three. So started with the BRCA mutation, the HRD plus BRCA mutation, and then all comers. That step down procedure then allowed them to, statistically, without having to spend alpha to make the assessment, to assess all three patient populations. And they did that not only with the progression-free survival outcomes, but they also did it from the quality of life aspects. So they assessed quality of life, and they expanded it down the cohorts. And the point was that if any one of those analyses was negative, they stopped. So as I mentioned, as it showed in the previous two other trials, that the addition of a PARP in this step-down way improved the progression-free survival to a dramatic degree. Again, the hazard ratios all in the low 0.2s, and with each larger cohort, the hazard ratios still rose, but they were still significantly positive. Now, one caveat that was different in ARIEL3 from the others is that they actually looked at what was the likelihood of response in the patients that were randomized. And you say, wait a minute, these patients were treated with chemotherapy. Yeah, that's true. But all three of the trials included patients who had only partial responses to treatment. So, and it was about 50-50, 60-40. In ARIEL3, it was actually about 30-70. So there was a significant number of patients who had a partial response to their chemotherapy before they got randomized to placebo versus their active compound. And so what we did in ARIEL3 was to actually look at what was the response rate to the drug in the patients that we could measure response in. And that happened to be a significant proportion of the patients that actually had persistent disease or had partial responses to the platinum. And what we showed, again, in those cohorts was that patients that carried a germline or had a somatic mutation in BRCA had about a 40% response rate when they were given the drug. So they had just responded to platinum, and then we gave them the PARP inhibitor, and then 40% of those patients went on to respond again. And it carried out to each of the additional subcohorts, but the response rates, as you would expect, were reduced as they lost their homologous recombination deficiency signal, if I want to use that term. So when we looked at the adverse effects in that particular trial, what we saw was that there were some very commonalities. So GI side effects, as I mentioned, nausea, vomiting, taste changes, weight loss. Those were very similar across the board. Some nuances in the ARIEL3 patient population that we saw that was well documented was a change in the transaminases. So we saw a slight increase in the significant increase in the transaminases on the average around below 2 times the upper limit of normal. That decreased as the trial went on. Another effect that was similar across the board in all the PARP inhibitors was a change in the creatinine. And these were well documented and reported. But as I mentioned in the beginning, the one side effect that we were concerned about and very happy to report did not occur in all of the patients that were randomized to a higher rate from placebo versus drug was the myelodysplastic syndrome, or the AML. The exclusion criteria for the 3 trials was also slightly different. In NOVA, there was a requirement that the patients who had had a response to the platinum, that the size of the individual tumor nodule needed to be less than 2 centimeters, and that CA125 values needed to be in the normal range. In the ARIEL3 trial, there was no restriction on the size of the tumor, but the CA125 had to be normal. And people were a little confused by that. But the intent was to try to identify a patient cohort population that were responding well to platinum. And they thought, or it was our consideration, that patients that had normalized CA125 but still had disease that was still visible by CAT scan may be in fact on their way to responding. And it's interesting that as I mentioned in the partial response outcomes, the patients in the placebo group, there were responders in that group. And so that might serve as some proof of the concept that these patients hadn't yet reached their maximal or optimal response time point because we had stopped the evaluation or stopped the treatment with the chemotherapy a bit early. But they had already normalized their CA125. So it was maybe a precursor of what their best response ultimately was going to be.